Chair, does that mean you're the boss of a number of other urologists?
Yes, means I'm the head of the department.
Is that more of an administrative thing, or do you actually supervise, learn from, teach the other urologists underneath you?
So it's a supervisory role in the sense that I'm in charge of the department. And I'll have, in my department, for example, there are 12 urologists and we have 11 residents and we have one fellow. So it's supervisory over them. I get to teach the residents and medical students as well at University of Virginia, which is great. And I also have my own practice where I see patients in the office and operate.
That's super. And University of Virginia is absolutely beautiful campus.
Thank you.
Yeah. So today we're going to talk about the classic questions, surgery versus radiation. And I hope we're going to get a bit more unusual in this conversation and more helpful than typically patients experience during the brief time they're with their primary urologist. Let's start by asking why we're doing either in the first place. What's the point of, cutting out the prostate or using radiation to impair the reproduction of cancer cells?
That's a great question. And I would say if you have low risk prostate cancer, you shouldn't be doing either one of those. So if you're a man who's diagnosed either with very low risk prostate cancer, which means you just have a very small amount of Gleason 3+3 and a PSA less than 10, you should not be doing surgery. You should not be doing radiation. You should be doing active surveillance. And for low risk men, meaning you have maybe a higher volume of Gleason 3+3, still a PSA less than 10, organ confined disease, you should be doing active surveillance as well, or at least having a strong conversation about it with your urologist to find out why do anything except monitor very closely for quite a long time until you actually need surgery or radiation.
Why?
So that's a great question.
Yeah, but within our system, I mean, we've been advocating or promoting the idea that what in the early 2000s we were calling watchful waiting and now active surveillance. And I think these days there are actual, subtle distinctions between the two, making each a valid term to use.
There's strong distinctions between the two. I agree. Yeah.
Yeah. We could talk about that in a minute, but what is it that why is that on the table when somebody has cancer cells in their body?
Because prostate cancer is really unique and it's not just cancer. You hear a cancer diagnosis and you think this must be terrible, it's aggressive, I have to treat it right away. And prostate cancer is really different. It's why in prostate cancer, stage isn't the most important thing, whereas in a lot of other cancers, everyone around you, your family members and friends will say, what stage is it? What stage is it? And in prostate cancer, that's one small part of the whole equation. The reason it's on the table, I think, if you get really to the heart of it, is because of PSA. And as much grief as we give PSA, we're kind of lucky to have a blood-based molecule that helps us detect prostate cancer 10 to 15 years before we otherwise would have. And so PSA was kind of developed or discovered in the late 80s. And prostate cancer screening really started in the 90s, which meant men went from being diagnosed about a third of the time when the cancer was already locally advanced or metastatic to all of a sudden being diagnosed like a decade or more before you ever would have known about it. So it radically changed prostate cancer from a really aggressive, dangerous disease to something that you're catching so early, you didn't need to jump all over it and treat it right away. But it took the medical community, and I think patients as well, a long time for us to really understand what we were doing and wrap our head around this. So why can we just watch cancer? Back to your question, why is active surveillance the right thing to do? We're catching the cancer 10 to 15 years before we otherwise would have. And depending upon a man's health or their age, maybe that 10 to 15 year earlier diagnosis means that they might never need treatment in their lifetime. Maybe this cancer isn't ever going to be dangerous. Maybe they're going to outlive the cancer and die with the cancer, not from it. And the treatments that we're going to talk about, surgery or radiation, they have really serious side effects, even in the best hands, even in the most talented radiation oncologists and surgeons, you still have side effects that affects a man's quality of life in terms of urinary function, sexual function. So why give someone side effects if you're not going to actually save their life, make them live longer, or give them a better life, right? Yeah. So that's why active surveillance is on the table. And I think I would clarify, watchful waiting nowadays means you just kind of monitor PSA. You're never going to intervene. You're never going to treat for cure. and just watch the cancer. Whereas active surveillance means we're going to watch that cancer, and when it changes, that's when you get your treatment for cure. But you have all those years of life with your great quality of life, sexual and urinary function, without having to take on the burden of the side effects instead of just the benefit of the treatment.
So just as like a hypothetical, if it weren't for the side effects, active surveillance, watchful waiting might be irrelevant. We would just go in, do what the patient wants the doctor to do, and be done with it.
Well, there are always going to be side effects, And if it's, let's say we took off the urinary function, let's say we took off the incontinence or the overactive bladder, whether you did surgery or radiation, and the sexual side effects away, you're still making somebody infertile with the treatment. You're taking them out of work for some period of time. You are taking them out of the activities they enjoy doing for some period of time. There's always risk with surgery. There's always damage to surrounding organs, no matter how mild, with radiation. So, I guess if you could hypothetically imagine a consequence-free treatment, that would be great. It just doesn't exist in medicine today. Something with zero risk, zero side effects, zero impact.
Yeah, we characterize, it's not like pulling a tooth out. If we're pulling a tooth out, Malecare would be irrelevant. We just make dental referrals or so for prostate cancer. The idea of early surveillance, early identification of cancer. My counterparts are in, around the world are mostly big on like find out early, get treated early. And then the patient is bumped into, if he's fortunate, is bumped into the idea of active surveillance as an option, as a legitimate treatment opportunity. And obviously a quandary, but perhaps a greater one for Black men, and particularly in the United States, where the disparity of prostate cancer killing Black men over white men is 2.4 times the rate. Do you think Black men have a different, and men of color, and perhaps indigenous men as well, should have a different discussion about active surveillance than white men?
It's a really good question. And a lot of it, I think, goes to healthcare disparities and access to care. But I don't think that Black men should have a different conversation, in the sense that all men should have access to active surveillance. All men should have access to the best information to help them make the decision that's right for them. And so I think withholding access to active surveillance from Black men is discrimination. You should not tell one group of men, you have these options, and tell another group of men, well, here's different options for you because of your race. And I know it goes to the point that potentially prostate cancer is more dangerous among Black men, but there have been studies that have looked at this, if you make sure their access to care is the same, then those differences go away. So what I would worry about is saying you don't offer all viable options to a man based upon his race, or change that based upon his race or ethnicity. I think it's important to share the information, make sure it's understood, but don't withhold options.
Yeah. The basic sort of predicate for active surveillance would be based on Gleason score alone, or other things?
So the risk category, and like I mentioned before, prostate cancer, we really think about it as a risk classification now, not as a stage classification. And part of the risk categorization is Gleason grade, PSA, volume of disease. So how many cores are positive? In the biopsy, you get a lot of biopsy samples taken. And so the percent of them positive goes into your risk category. And your stage factors in as well. So your stage on rectal exam, on ultrasound, on MRI, but all those go together to create a risk category. And there's different ways to do risk categorization. There's Catan, there's Parton tables, there's NCCN, there's DeMico, but they all kind of put you into a category where you range somewhere from very low risk to very high risk.
Yeah, and what you just talked about are like decision trees / algorithms that sort of just say this, yes over here, no over there, then yes over there, no over there, till you sort of get to.
These aren't actually, these aren't decision trees or those algorithms, and those do help patients somewhat. These are actually risk stratification models. And so you put your information in, And it can tell you a variety of different things, like it can predict your pathologic features, it can tell you survival, likelihood of needing a different treatment option, but fundamentally it's categorizing your risk of disease, your risk category.
And the Catan has been tested over a number of years now, as well as others. They're not perfect, but they're good, sort of suggestive, highly suggestive, almost authoritative suggestions. Would that be fair to say?
I think that they're really useful statistical models.
Yeah.
And I think it's, I mean, fundamentally, you get into your risk category, which helps a lot. So that's useful. You have to remember they're estimates, and each person is more than just a statistic, and that they're only as good as the information that goes into them. So for example, if you have a biopsy that misses the cancer, or gets only a small part of it, or is graded as a 3+3 when in fact it is a 3+4, or misses something else, it's only as good as the information that you have.
What do you think of the genomic tests that are available?
It's a controversial topic. So I did all of my training on the West Coast at UCSF, and a lot of those genomic tests were validated there using the active surveillance cohort at UCSF. So I've seen a lot of value in them. I think that they're very useful for men who are trying to decide if they want to be on active surveillance or if they want treatment. Because to some degree it can help men, especially on the borderline. Let's say you have high volume Gleason 3+3, or let's say you have Gleason 3+3, but your PSA is discordantly high and you kind of can't reconcile what's going on. Or if you have just a very low volume Gleason 3+4 with less than 10% 4 of in one core, and you want to know, look, can I really do surveillance? What's my risk? Do I look more like the Gleason 3 component of my disease, or do I look more like the Gleason 4? I think it can be a really useful tiebreaker or additional information, but a standalone test is probably not that useful. It's all part of the risk stratification.
And that's the value of having a good doctor to work with, to sort of distill all this and try and work with the patient to make sense for both of you around this.
Yeah, it's a lot of data to put together. And I think with prostate cancer, it's hard because there's so many choices. And so much of it really is put on the patient of, choose, do you want this? Do you want that? What's important to you? And it's overwhelming when you get a prostate cancer diagnosis because all you think is cancer, and it's scary.
Yeah. So let's talk a bit now about the person who's not really active surveillance probably isn't the wisest choice, or or actually we should say perhaps the patient and the doctor have had a long and comfortable discussion about options, and the patient has decided, I'd like to actually do something that takes care of cancer cells in a more active way.
Okay.
Now what? What are you talking about now in the office?
So now you're talking about surgery and the side effects of surgery, which is radical prostatectomy. And that can be done robotic or open, but it's fundamentally the same idea of taking the entire prostate gland out and the seminal vesicles, and you cut the vas deferens. So that means no more fertility, no more ejaculate at all, no fluid, or leaving the prostate in the body and doing some form of radiation. And radiation comes in so many different forms nowadays, but it's really one or the other. And then the conversation I like to have is, let's talk about the side effects. Let's talk about secondary treatment options, or like backup plan. What if it doesn't work? And then let's talk about your life and how you want to live your life, what's important, your job, your activities. Do you want more children, your partner? I think those are all important elements of the conversation.
Do you think rural versus urban plays into it, economic capacities, things like that? I
don't know that rural versus urban necessarily. I think more what someone does for a living, if they're working or if they're retired, and what kind of job they have if they're working, what kind of things they like to do. A lot of people who are retired are still really active and focus on activities that are incredibly meaningful to them. So I think it's how you spend your time. What do you do for a living? How quickly do you need to get back to work? Can you afford to take time off for one or the other? Who do you take care of in your life? Because some patients have a lot of people they need to take care of, to actually physically take care of, watch out for. Those things all play quite a bit. Economics of it, I don't think there's a cheaper option. I think it also depends on where you're receiving care.
Yeah, in terms of, what do you mean by where you're receiving care?
So some states have different insurance programs for people who aren't insured or are uninsured, or don't have good insurance, for example. Even though there is Obamacare, not everyone chooses to pay for it. So some people really don't have insurance. Some states actually have, for example, California has Medi-Cal, so everyone can get insurance somehow. Other states don't necessarily have this.
Right. And outside of the United States, many countries have national healthcare systems. I think there's a bit of a myth that you have to wait longer for treatment in other countries. I mean, I wait a month or two to see my doctor. I mean, I don't think it's much different anywhere else. Yeah,
Well,
and there.
yeah, it depends on where you're talking about.
Yeah. Well, I'm in New York. I mean, but
no, I mean, what country you're talking about.
Yeah, yeah.
Quite a long wait, for national health care.
And this is we're doing it because we're online. We have an international audience. There are many people who don't have access to radiation therapy at all. There are many people who have to cross borders at over great periods of time and traverse places by themselves because their family can't accompany them. There are migrant workers who are in a host country that may have good health care, but their family and friends are thousands of miles away. Lots of different considerations around this, but the bottom line is if you need cancer treatment, I mean, you're stuck with what's on your plate. You got to do you can't take care of your family in another country if you're dead, or truly incapacitated. The idea of surgery and radiation, though, I mean, it's good to know that we could make a choice between one or the other, but why is there one or the other? I mean, why haven't investigators just focused all their intention, all their actions, all their finances and resources on making either radiation the best possible treatment or surgery or finding some hybrid of it? I mean, why are there these options?
I guess both work. So it's good to have choices. For high-risk patients, you do need a combination. So it's not just surgery or radiation. It's usually radiation with hormones or surgery followed by radiation and hormones. So it's a combination. Radiation is a backup plan to surgery, meaning if you do surgery and cancer cells are left behind or the cancer were to come back in the pelvis, you do radiation later. So the two go together. Surgery doesn't cure everything. You can't, if the cancer's metastasized, then surgery doesn't really add any value. And then you're left with radiation. So if we were to say, okay, we're only going to choose one treatment, let's put all of our effort on surgery, then we're essentially ignoring everyone who has metastatic disease. Or I guess contrastingly, if you go just with radiation, then anyone who's had radiation for a different malignancy, let's say somebody had colorectal cancer and already had radiation and can't get more, then you're left without an option, really, or a curative option. So I don't know that it would be wise of us to really just focus on one and totally get rid of the other because they get used together so frequently. Yeah,
I mean, as the more we talk about prostate cancer, the more a patient newly introduced to the world of prostate cancer sees there's a lot to learn, that there's no clear pathway. It all seems so staggeringly impossible to understand, that, the best computer system could never even, churn out the best choice. But in a way, we're in a good place in 2020, 2021, that we do have all these options because we can tailor with a higher degree of precision than we did in the past, the specific treatment opportunity for the specific patient at this particular time. We can scan and sort of understand what's going on internally now with more precision and then attack both location and stage, or the amount of cancer, perhaps, is a more pedestrian but clearer way to understand it, and where those cancers are actually turning our bodies into something not particularly nice, destroying our bones and, our brains and such. Is that a fair way to describe what's going on at this time in this place?
I think that's fair.
What,
Prostate cancer, uh, prostate cancer, like I said, it's almost like different types of cancer. That's what makes it so complex. It's not like one thing. So you have your low risk cancer, your high risk cancer, and they're almost like two different things. It's almost like we need a different name for it, because low risk cancer, it's not going to go to your bones. It's not going to go to your brain. You need to just pick, do you want surgery? Do you want radiation? Because you're probably not going to need a backup plan. You're probably going to be cured with whatever you choose, which is why active surveillance is something we recommend to people right off the bat. But with high risk cancer, you sure need your options. And you do need to understand what's going on and think about, if this doesn't work, what's next, and have things planned and staged correctly. So you're right. There's an overwhelming amount of information to process, to learn. It's almost like learning a new language. So I think one thing patients really can do to advocate for themselves is make sure you see both a surgeon and a radiation oncologist. Don't just see one. And if you're getting a second opinion, don't just keep getting second opinions with surgeons. Make sure at some point you get the other side, hear from radiation oncology as well, because we are two different kinds of doctors approaching the same problem. And no matter how open-minded we might be, no matter how much I try to be a level playing field about surgery versus radiation, I'm a surgeon. So my natural bias is probably going to be slightly towards surgery. And so when you see a radiation oncologist, maybe his or her natural bias is going to be slightly towards radiation. So you get a more balanced perspective when you see one of each. And I think that's one thing patients can really do to try to get their head around what's going on with their cancer and what are their choices.
and it's worth saying at this point, a second opinion, and perhaps third, on your pathology. That
Yes.
another pathologist at a different location should look at your slides.
Yes, because it's very subjective. And it depends on whether your specialty is, urologic oncology, urologic pathology, or do you do everything? How many do you see a year? So that's a really, really good piece of advice.
Yeah, just as an aside, one thing that comes up, it's probably within the top 5 of frequency. Can your Gleason score change over time? Let's talk 3 to 5 minutes on that, because that's kind of interesting. How would you respond to that?
Yeah, so assuming you mean over time, like if you're on active surveillance.
Yeah, patient's told he's got Gleason 6. Some patients just say, grab that, walk away, and are happy as clams for the rest of their lives till their natural deaths. And they're actively surveilling as best as, as much as they fit it into their lives. But there are patients in our support groups that say, well, wait a minute, is my Gleason score, if I do another biopsy, is it going to change? Or, is it really that the primary biopsy, the initial biopsy, just missed something?
Well, that's a great question. So first, if you're doing active surveillance, you are getting repeat biopsies. It's not an option. It's part of it. So, and that's the most important part. So if you choose active surveillance, it's not like you just get your initial Gleason 6 and that's it. You're getting periodic repeat biopsies, definitely at the first year to 18 months, and then maybe every 2 to 5 years thereafter. So you are getting it surveilled, which is very important. And it does change over time for some people. So, and that's the most critical part of active surveillance, is if you have a Gleason 3+3 and you're following it over time, and all of a sudden there's a little bit of Gleason 3+4 or 4+3, and that 4 component becomes present, starts to grow, that's when you're going to want to get treated, when you have an increase in your grade. So it really does change over time, because you can imagine if there's a cancer cell that starts out being not so bad, like Gleason 3 is not that bad, and it starts to get more mutations, that's going to make it become more aggressive. And that's going to change a Gleason 3 cell into a Gleason 4 or a Gleason 5. So it really does change over time. Now, on the other hand, some people, let's say you got a biopsy and it was just, 8 cores. So the minimum number of biopsies required, or the minimum number of cores required to make it an acceptable biopsy. And you never got an MRI, and nobody, the ultrasound guidance really didn't notice anything. So then you could wonder, hey, is there something else in the prostate, especially in the anterior part, that didn't get biopsied, that has been there and it's been growing over time? did you really have that all along, or did it arise? And so the answer to your question can actually be yes both ways, which is why on active surveillance, you have to really make sure you get a thorough biopsy. It's not missing the anterior cores. You're getting some type of MRI imaging or good ultrasound along the way to make sure nothing got missed.
Yeah, and good that you mentioned the anterior. We shouldn't spend a lot of time on the geography of a prostate, but there's a part of it that, because it's, I don't know, correct me if I'm wrong, like it's painful for the patient to, have a poke there. Typically that's not part of the biopsy. Is it appropriate for a patient? Is it a good idea for a patient to just, say, do it, doctor, go in, I'll just grit my teeth?
So you can anesthetize that part too, just like the rest of the prostate.
So why
So it
isn't that
shouldn't
done?
be any more painful.
So why isn't the anterior tested out, biopsied out?
Well, it is by a lot of people, but not everyone seems to biopsy the anterior cores. And I think it might be part of different people's practice is slightly different. And geographically, it's different. Where I trained, anterior cores were a routine part of the biopsy. So that area got anesthetized. Patients couldn't feel it. And you take the biopsies from the anterior cores. Some places, they're just not taught or trained that way. And it's not like it's a mandatory thing to take them. But I think if you're a patient and you're getting a biopsy, I would ask. I mean, I tell my family and friends who aren't getting care with someone I know, like, you better make sure they take anterior cores, because for anyone who's listening to this, if you go through a prostate biopsy, you want it to be a good, thorough biopsy all at once. You don't want to just miss a few spots or do a few less. Like, just get it done. Do a good job.
Yeah, I mean, if you're there, do it.
Do it, right?
Yeah.
But you can anesthetize that spot too. There's no reason it has to hurt more.
Yeah. So, I mean, and this leads to the idea that some doctors do things differently.
Mm-hmm.
So what's a patient supposed to do with that idea?
I think you're right. Patients do things differently. And just knowing that is probably half the battle. It's not like there's a recipe we all have to follow. There are certain things, guidelines, standards for a lot of medicine, but not for everything. And I think as a patient, just having the information, knowing what questions to ask, finding someone who's willing to talk to you and respects your questions. A doctor should never be irritated by your questions, or you shouldn't, as a patient, feel like you can't ask questions. But then just going places where you know that it's an excellent place for prostate cancer care. That's a good place to start.
Yeah, I mean, and we hope everyone has the opportunity to access quality care. I mean, that's why I was asking earlier about rural versus urban. I mean, we have groups that before COVID were active in rural areas, one on a Native American reservation, Navajo Nation, and others, most of them in medium to large size cities. There's a distinct difference to the opportunity to find consultations, let alone quality ones.
But the one good thing about COVID, I would say, is that there's so much telemedicine now. And so it doesn't matter where you are, you can get a visit, and more likely a telemedicine visit, with any expert across the country now. So it's probably one of the only good things that have come out of this pandemic.
It is extraordinary. I mean, just this conference. I mean, typically we'd have a weekend in New York where we'd have a faculty of 14 or 15 doctors. This year we have 43. And from all around, from Australia to Europe, with a large number in these states in between. But I mean, it's wonderful. Actually, let's talk a bit about, and we have about 10 minutes or so to go. In the last 6 months or so, tell us about your experience with telemedicine and how it's been good, bad, and in between for you and your patients.
We started it where I currently work at University of Virginia. We were able to kind of transition over very quickly to telemedicine from an experience where we really hadn't had it as much for all patients. In Virginia, there was a rule where you had to be at a designated telemedicine facility as a patient. You couldn't just do it from home like you and I are doing today. And then with the CMS rules changing, it made it so we can all do these things from home. So patients at home could have access, which is wonderful. So we quickly set that up, started doing it. And I think it's been great, especially for patients who live remotely and just can't travel really far, don't want to travel really far for just a conversation where you don't have to do a physical exam. And it's also nice during COVID because there's limitations on how many people can come with you to the hospital, whether you can have a visitor, can you have your spouse come or your child or a friend. So you can actually have the whole family on the other end of Zoom, where even in normal days, you couldn't have that many people in a waiting room. So sometimes I'm Zooming and or I'm doing whatever telemedicine platform we're on, and there's a whole room full of patients behind the patient, and we're all kind of talking and having a great conversation. I think that's the good side. The bad side is, if you don't have a good connection, if you have limited technological expertise and you just can't get it working, that's frustrating. Yeah.
Yeah. And aside from the DRE, is there any reason that you feel you need to actually touch the patient?
I don't feel like I need to touch them, but I do feel like sometimes I need to see them in person. So you can kind of get a sense of somebody, of their fitness, of their breathing, of their mobility from being in a room, actually talking to somebody, taking a look at their belly, looking for scars, where I can't see that as well on a monitor. And it's impressive, we all sort of forget what things have happened to us medically over time. And so it's not uncommon for me to ask a patient, have you ever had surgery? And they say no. And then I look at their belly and there's a big scar and they're like, oh, that was from when I was a child. I completely forgot, but it was a major surgery. So, we all just tend to forget because it's not a part of our day-to-day life anymore, what we've been through or what happened to us in the past. So I do think at some point you have to meet your surgeon face-to-face, and it's really valuable. But I think just preliminary discussion, it's great to do it through telemedicine. And follow-ups too. If everything's going fine, it's great to do follow-ups this way too.
Yeah, and you can make it more appropriate for the patient and yourself, in terms of time. We're doing this conversation on a weekend. I've done a few for this conference at 3 a.m. to meet a time zone differential. It's kind of funky to do these kind of things at 3 a.m. The idea that we have access predicated by our bandwidth is both challenging for those who are economically challenged, but for those of us who have good bandwidth, it's extraordinary opportunity. Mm-hmm. And I imagine for you as well, in a gratifying sort of way, because you're actually in the patient's home. And they're more relaxed, I imagine. Can you speak a bit about, do you notice that, a different sense of calmness versus office versus telemedicine visit?
I haven't really, but I'm going to pay attention to it now. That's actually interesting. I noticed that people tend to ask less questions when they're home. We stay on time more, and it might be because it's interesting, on a telemedicine call, you cannot run late and you can't extend one visit. If somebody shows up to the visit 10 minutes late, like they would in the office, or half hour late, you can just sort of run that visit a little bit later so they still get enough time with you, but it does disadvantage the next patient. Whereas on telemedicine, it's on a time schedule. So the struggle I have is when I can't connect on time, or the patient can't connect on time, or we're struggling and DoxyMe's not connecting, and then we call on the phone and do you have the right link, and did you spell my name correctly? This stuff that actually really eats into the visit, because you can't run it another 5 to 10 minutes longer to make up for it like you could in the office.
That's very interesting. That until this moment hadn't thought of that one.
Yeah. People who just want to keep talking, or have more questions, you actually have to cut it because your next telemedicine is supposed to start at that moment. And on Zoom and things, you're a minute late and it seems like forever. Whereas in the office or in real life, somebody rolls in a little late and it's not such a big deal. But
yeah, depending how good the coffee is in your waiting room.
Right.
Yeah. In the time we have remaining, let's talk about, when you're in the OR, you're about to do surgery. Patients are under anesthesia and are not awake for that. But what's that like for, you're doing Da Vinci robotic stuff. So you're looking through, something. Your hands are on 2 controllers. Mm-hmm. Is that fun? Is it like going on an exploration? Are there surprises?
It's a lot of fun.
Yeah, go ahead.
Yeah, it's a lot. I mean, surgery is fun. If you're a surgeon, surgery is fun. It's what we all love to do. It's why we spend so many years training, because anyone who's doing this is really likes it. It's the best part of our day. And it's for anybody who has a hobby that they enjoy with their hands or fixing things. It's that gratification, except different too, because you're helping a person and the person's meaningful to you because you've gotten to have a relationship with them as your patient. So it is a ton of fun. It's always a surprise. Every single time is different. I never get bored with it. Some people say, well, don't you get bored just doing prostates or kidneys and the same thing? And it's never the same thing. Everybody's a surprise. There's always something different, something interesting. And yeah, it's a great way to spend your day.
Yeah. Well, good that you spend your day that way, taking care of your patients, our community, and thank you very much for spending time with the thousands of us listening in now. I think the confidence around, you've helped increase confidence, or for those who have chosen active surveillance and have given a bit more of an understanding of the guideposts as to when to pull a trigger around active surveillance. And I think people considering radiation versus surgery now have a bit more of a sense of what kind of conversations to have with their doctors and how to get more doctors involved in their lives. No matter what that sounds like, it's a good thing to have more doctors.
It is a good thing. Yes.
Yeah. All right. Thank you very much for being with us, and welcome to our conference.
Thank you so much. It was a pleasure talking with you today. Thank you.
Thank you, Dr. Greene.